Welcome to People Unplugged, the podcast from the creative team at People Unboxed. I'm Westy, Digital Director at People Unboxed. This is the People Unplugged podcast. Well, good afternoon, everyone. Good to see you again on another show. Bit of a different one this month. Have you ever thought about how we take our sight for granted? Think about a world as you see it right now and imagine that suddenly gone. Now imagine a world where a simple procedure could restore that vision and therefore transform lives. Well, this month, we're talking about exactly that. I'm really pleased to say I'm joined by Bonnie Henderson, President and CEO of HelpMeSee, who, along with her team, are using cutting-edge technology to try and solve that exact problem. So they're training eye surgeons worldwide to tackle cataract blindness, and their approach is truly revolutionary. So without further ado, I'd love to dive into the incredible work Bonnie and her team are doing. So firstly, Bonnie, great to see you again. How are you?
Great. Thank you so much, Westy, for having me on. It's great to see you too.
Yeah, that is an absolute pleasure. And perhaps I should have said multi-award-winning work you're doing. So just for full disclosure, that's never going to get old. Always sounds great. So Bonnie and I finally met face-to-face, and we've spoken over Zoom and things, but we managed to finally meet face-to-face in November last year, where the project we're going to discuss today picked up 2 golds, I think, and is multi-award winning. These 2 golds are at the Learning Technologies Award, including best use of simulation, which is what we're going to be talking about. So I think we should start there, Bonnie. Tell us about the work you're doing and then specifically this project.
Well, thank you for having us. And I like the sound of multi-award winning. That's, this is when I do a hair toss. Is that? But thank you for having me on, really to shed some light, not to use a pun, on the global problem and hopefully part of our solution that we're hoping to lend to the rest of the world, really. So as you said, cataract blindness is a huge problem. It's actually the #1 leading cause of blindness in the world. And in our countries, whether it's UK or the US, we take it for granted because we have great educated doctors, surgeons who do cataract surgery. And for people who are well trained, it's maybe 15 minutes or so. It's a fairly short, very safe procedure. And when you're well trained, it's actually something that people do as bread and butter for ophthalmologists. And let me step back and explain kind of what a cataract is,
Yeah,
because
that'd
a
be
lot
great.
of people, yeah.
And
So a lot
use
of people
the M&M analogy, Bonnie, because I'll be gutted if you don't.
Sounds good. So a lot of people actually think a cataract is a film that grows over someone's eye. I've heard this so many times, and I'm sure your relatives probably said the same thing. But in fact, what it is, it's actually the lens inside your eye that starts to turn hazy. And I like to explain what the lens in the eye is kind of like so there are 2 types of M&Ms. There's a peanut M&M and there's a chocolate M&M. So I'm actually talking about the chocolate M&Ms. And the chocolate M&M has that candy coating, and then inside there's that chocolate middle. So it's very much like a cataract where we have an outside coating called a capsule, and the inside is actually the lens material itself. And so what happens in a cataract is that the inside chocolate middle becomes hazy and opaque. When you're young, it's usually clear like glass, so you can see right through it. So you can imagine as that chocolate middle gets actually hazier and hazier, you can't see through that chocolate M&M. So in cataract surgery, we actually open up that capsule, and in real life, that capsule it's more like a soft tissue, almost like a grape. So you open up that grape skin, you take out that chocolate middle or that pulpy grape, and then in the grape skin or the candy coating, you actually put in the artificial lens that goes in the eye. So that's what a cataract is. And like I said, in surgery, we actually do that regularly. We put in a new lens that actually can correct your vision, and then people do quite well. Unfortunately, in most parts of the world, the educational system is not as well established as in our countries. And the doctors that actually go through training, even if they are an ophthalmologist and they went through ophthalmology residency program, they actually never learn to operate. And so they leave their training, they've never learned to operate. And so they are on their own trying to operate on their own. And it's very difficult to actually learn how to do the procedure. Even though it sounds really simple, it actually takes years to learn how to do it. And so what we're trying to do is use a high fidelity virtual reality simulator to actually bring the simulator to countries around the world that are low and middle income countries, and use a simulator to really jumpstart the surgical education of these surgeons. And so we have found
Before
that
we
it's
jump into
successful.
before we jump to that, just paint the picture of how common cataracts is. So, is it something that is it a hereditary thing? Is it genetic, or is it something that? 'Cause I remember you saying before we're all going to get it at some point. Have I got that right?
No, you're absolutely right. So the cataract really isn't a disease per se. It's actually just a part of aging. So every single person who's listening and watching, we're all going to get cataracts if we're lucky enough to live long enough.
Sure.
So it's a natural aging process. So every single person is going to be affected by this. So this is not a rare disease. This is everything. And so that's why it's so crucial to educate people about how to take care of cataracts because it's not going away. And in fact, everyone's living longer and healthier.
Yeah.
Especially in the countries that, we do have a lot of M&Ms. We eat a lot of M&Ms, so we live longer, we get a little heavier, all the rest. But we do live long enough that we all get it. So it's something we should all learn about.
Fantastic. So you mentioned simulator there, and we're going to have to get into that because I think you're using flight simulator technology to train eye surgeons from memory, and that's such a cool and unexpected approach. So how did that idea even come about?
So our founders were Al and Jim Yulchi, and the Yulchi family are an incredible family. They actually are the ones that really pioneered the idea of simulation-based training for aviation. So in the 1950s, Al Yulchi was the founder of a company called Flight Safety International, and they are the people that really thought about pilot training. And they said, wow, we really should do this better because back then pilots were actually very similarly the see one, do one, teach one almost, where
Yeah,
they,
yeah,
would go ahead and, learn in the classroom and then they would probably try to go and have a real flight with a pilot. So they created this industry of simulation based technology and simulation based training. And then they found that it was so successful with pilots, they really wanted to turn their attention towards medical training and surgical training. So the Yulchi family, and Al sadly passed away about a decade ago, but his son Jim has really taken up the mantle and has been leading HelpMeSee. And they've actually created this industry of simulation-based technology for cataract surgery and now HelpMeSee. And so they have found that the simulation-based technology can be so realistic and the fidelity can be so high that they've created this simulator that has haptic feedback. And what that means is the actual surgical instruments that you hold, they've been able to create a simulator where you can actually touch and feel the tissues in a very realistic fashion. And it's not just the visual parts, it's actually the tactile parts, which is really what's fascinating.
and how does this stack up against how surgeons would normally learn? So maybe take us through an example where, especially in places where resources are tight, I guess. So, we're fortunate enough, it's probably fair to say, in the UK and the US. But imagine, other parts of the world that we're talking about here. So, how would those surgeons normally learn to do these operations, or would they not?
So most, unfortunately, for example, let me take Madagascar. We have a center there. So in Africa, the training is really all over the place. So in some countries, they have a very set system and they have thought through exactly how to train a surgeon. But unfortunately, most of the countries that have low resources, oftentimes they don't even teach surgery at all. They've watched surgery, they've observed, and potentially even maybe assisted by, handing instruments, but they've actually never done the hands-on. So what would happen is they would watch a bunch of surgeries and then they were basically let loose to take care of patients. So what would happen is the surgeons would try to do surgery on their own. And as I said, it's quite difficult. And so the complication rates would be very high. And so the outcomes would be poor and a patient would not do well. So then what would happen in these rural villages, they hear one villager had a very poor outcome. They became blind after this kind of surgery, this attempted surgery. And then culturally, everyone would say, no way, we're not going to have surgery that leads to blindness. And so it really causes fear and confusion, and people end up not seeking care. So, number one, sometimes they don't even get any training, they just watch. In some of the programs that do have some type of training, they can use wet labs, for example. So a setup where they actually take animal eyes, for example, or synthetic eyes if they have the funding or they get a grant, and then they try to do the surgery on a pig eye or a cow eye. But that's definitely better than nothing. but it's really not as similar as a human eye. They can do some steps, but most of the steps really don't relate to a human eye. So although they have some of the tools, it's really not as proficient. They don't lead to proficiency as they can with a simulator.
So you said you've got a place in Madagascar. So how exactly does that work? So do people come there, and is the simulator like a physical thing that's there and they go and practice with? Take me through how that works.
Sure. So what one part of what we think is really crucial besides just a simulator is actually the instructor that's sitting next to you. So the huge benefit of our simulation-based training is that we don't just throw a simulator and say, good luck, have fun, bye-bye. We actually bring it with our team. So you are sitting with a cataract surgeon as you learn how to do the surgery on the simulator. So in places where they are already plugged into a good residency program, in the US, for example, the manual small incision cataract surgery procedure, we call it M6, that usually takes about 4 days or 5 days potentially to do the course. And each day is about an 8-hour day sitting with a cataract surgeon with you the whole time. In places like Madagascar, if they're not plugged into a good training program already, oftentimes it takes about 2 to 3 weeks for the training. And so they're spending the entire time sitting next to the cataract surgeon, really coaching them step by step and giving them feedback constantly at the same time. So it's not just the simulator, it's really the simulator plus the instructor. Additionally, on top of that, they actually have pre-simulation based training materials that they have to go through. So we have an electronic book that they have to really get through. We have electronic learning systems, the e-learning systems that they actually go through. So it's an online program that's interfused with videos and conversations and materials that they can actually read and so learn ahead of time before they actually sit down at the simulator.
Have you got any idea on the numbers we're talking about? How many surgeons have we trained so far?
Sure. So we really started training around the time of COVID, unfortunately. So right around the beginning of 2020 is when the program really launched. The HelpMeSee started around 2012, but the simulator really wasn't fully functional and ready for prime time until about the time of COVID. So we had a slightly slow rollout because of COVID. But from then until now, we have trained about 4,000 surgeons. And it's really, even if you actually count up the number of courses that we've given, it's higher. It's probably around 6,000 courses or so. And that's basically in all around the world. So in Africa, in Asia, so China, India, we're in Latin America, we're also in Europe, in Strasbourg, France, we're obviously in the US. So we're basically everywhere. So people can, and hopefully growing. So we're really expanding to more and more centers, hopefully every few months and every year.
I think I'm right in saying this is far more than just fixing eyesight, though, right? So I remember you mentioning to me before that you're talking about impacting families, impacting communities, and even addressing gender equality. I'm sure from memory we saw that. So maybe you can take us, or maybe share a story that really brings that home, and maybe a moment you saw that sort of ripple effect from, okay, here's successful surgery, or here's an area where we should be, and how that's changed lives, maybe both for the patient and the healthcare team there.
That's a really important point. So blindness with from cataracts, although it really obviously impacts the patient, it actually is a bigger and broader problem. So what happens oftentimes in countries, low income countries, if someone in the family, a grandparent say, or a patient who's in their mid 50s or so, they become blind from cataracts, now they can no longer leave the home very successfully. And so oftentimes they have to have a caretaker. And so what happens is the person who actually has to stay home and take care of that person is oftentimes the youngest female in the family. And so what happens is now that person, oftentimes a child or a young adult, can no longer go to school. They can't hold a job. And so what it does is perpetuates the cycle of gender inequality. And so that now female family member has to give up and sacrifice their future to take care of that family member. So it does have a broader impact than just that patient alone. Also, think about the resources that impacts the family. So if that person is supposed to be earning income, having a job, they no longer can do that, as well as the loss of income from that patient who actually has become blind. So financially, they're struggling, as well as having a socioeconomic impact, it really impacts the family. So that's the caretaker. But also, if you actually look at the statistics of who actually can get care or does actually get care, it's unfortunately unequal. So although cataracts are equally prevalent in males and females, when you actually look at who actually has care and has cataract surgery, it's mostly men. So I was in Rwanda a few months ago for the African Ophthalmology Congress, and there was this great speaker. I wish I remembered his name, a doctor in Rwanda, and he was describing that they had a outreach program where they do a training, a triage program. So they go out into the rural communities. They do free screenings for eye care, so they can diagnose cataracts or glaucoma, diabetic retinopathy, and they offer free care. So they went out with their team, excuse me, and they actually screened hundreds of patients. And they found that approximately, let's say, 300 patients needed cataract surgery. So those patients were triaged, they were examined, they were consented, they discussed surgery. They had planned for free transportation to the surgical center, free surgery, free everything. And so they signed up around 300 people, and they were equal, about 50-50 men and women needed cataract surgery. And when time came for the surgery, so they were all ready and waiting, the buses were loaded, they brought them there. And what ended up happening when they came, the far majority were men. So the women, for whatever reason, chose not to come, even though they had free access to great care. They knew they had cataracts, but they don't show up. And some of it could be just individual preference, fear of surgery, or just the thought that maybe they don't deserve surgery. So there's a lot of that cultural type of barrier. But also I think there is some preference given to males in the family. And so a lot of the families may say, no, you don't need care. Let's first give the surgery to this male family member. And so the delivery of care is also unequal, as well as the impact on the family.
And is that, you've said about eradicating cataract blindness globally? That's the goal, and a fantastic goal it is. What you've just described there, the cultural side to it, do you see that as the biggest hurdle that you're facing in getting that training out to everyone who needs it?
It's interesting. They've actually done studies as to why there are so many people who have cataract blindness when there is a cure. And it's multifactorial. So I think that we think, oh, it's just finances. They don't have the resources, or oh, they don't have enough surgery, or they don't have enough. I mean, or equipment. But in fact, it's actually more complicated. So there are several factors. Number one, the cultural aspect, like you said. So misinformation about what a cataract is, what is the solution, and then the fear of surgery itself is a big one. That's actually one of the major ones that we find, is the lack of knowledge about what it is, and the reluctance. Oftentimes we hear, I'm old, this is just normal part of life, kind of how we deal with arthritis, right? When we wake up, we all kind of get out of bed, we're like, oh, that hurts. And now I'm exactly. Exactly. But, and so if we had a cure in, 15 minutes, we can get rid of all of our arthritis. That would be amazing. But we kind of live with it. And we're like, this is part of life. And that's sometimes what they say. They say, it's part of life. So that's a big factor. But yes, in terms of lack of resources. So they don't have the ability to, access a doctor who can diagnose them properly. They don't have transportation. So they don't have family members that can travel with them. And oftentimes they have to travel for days to get to a doctor or a surgery. And so that family member has to take off many, many days of work. So oftentimes it's lack of family support. So there are many, many reasons. We can't tackle every problem. So at HelpMeSee, we're just trying to tackle one part of the problem, which is really the lack of skilled caretakers. And so that's what we're trying to hope to improve.
And finally, on that, just going back to the gender bit. So we've talked about the patient. Is the same true of the surgeons that are coming through? Are the majority of them men? And is that what you're seeing?
Yes. And that's true in everywhere in the world. When you look at the US, for example, if you said 100% of the ophthalmologists, what percent are male and female, it's about 30 to 35% are women. And some of it is just because historically medicine was a male dominated field. When you look at the medical schools graduating classes, they're 50-50. And so it's just going to take time for those numbers to get to an equilibrium. So I have no doubt that in countries of high resource countries like the US and UK, that's fine. So you don't see a lot of gender inequality in care providers. However, in places that are low income countries, there definitely is a higher percentage of male providers. What we're trying to do is similar to microloans. So you've probably heard of microloans in Africa, for example, where businesses, they've given small loans to women in the community. And what that has done has had a broader impact to their community. So it's empowered the women in the community to have some ability to earn an income and have a little bit of leadership. And so therefore they have leadership positions in their community, and it actually changes and evolves a community into a better place. So we know that when we actually look at board membership, for example, if you have men and women, people, diverse backgrounds, diverse voices, you actually have a better board because you bring in people with different perspectives. And so we see the same thing in leadership in communities. When you have different types of leaders in a community, whether it's different lived experiences, different genders, it definitely lends to a healthier community. So what we're hoping to do with Help Me See is we're trying to educate female surgeons specifically. We educate men and women, but we really want to add that emphasis to really educate more women to bring that balance of power so that now women are now skilled in something. They have an ability to bring in revenue. They're respected in their community because now they're healers. They can actually bring something of benefit to others. And I think that really adds a lot to that stature of that person. And that really makes that community a healthier, more progressive community.
And it'd be fascinating, wouldn't it, to look at the data going forward if we get to that equilibrium, which would be brilliant. Where
Mhm.
I wonder how many of the when you said that that you had the same amount of male and female coming along, and actually the vast majority were male. I wonder if you had more female surgeons, whether people that more females would come to those female surgeons. We don't know that, but I can imagine. I don't know. I can only equate it to. I can imagine not being female. I don't know, Bonnie, but I can imagine. My wife would be more comfortable going to see a female gynecologist, for example, and maybe the same's true there. So if we have more female surgeons, will we see more females coming for what is? I'm not
Yes,
certainly not
yes.
belittling it, but what you're saying should be quite a routine operation and is basically life changing.
Yes, absolutely. And your instincts are correct. What we find worldwide is the women patients tend to prefer caretakers that look like them, that they can relate to.
Yeah.
So even in the US, a lot of people, when they're female, they prefer to go to a female provider. Now imagine in countries where the religious situation is different, where women have to be with women. So in the Muslim countries, where especially
Yes.
in the strict Muslim countries, women cannot go to male doctors, especially when it's something that they have to disrobe. So you can imagine where, a female provider is really, really important. And in those countries, the separation of male providers and female providers, there are a lot more male providers than there are female providers. And therefore the female population, they have fewer care providers that they can call upon. So you're absolutely right. So it's not even in low resource countries, even at high resource countries, if there are some cultural religious boundaries that they have to really adhere to.
Fantastic. Bonnie, it's a captive audience, right? I've got you. I'm gonna. I know from speaking to you before. You're far more than just sight. Okay, you've dealt with other things in the past. I'm pretty sure we've discussed that. So here's one for you, and I haven't prepped you for this. So if you can't answer it, that's absolutely fine. I was reading an article last week in the UK, and it's about how the government are planning to use, or they are already using AI to analyse mammograms, breast cancer screening. I think there's chest X-rays for lung cancer detection in the UK, etc. I know Help Me See already use some pretty innovative technology. So just on a wider scale, as a medical professional, take us through the role you see AI having. Maybe it is for the future of cataract diagnosis. I don't know, but maybe if it needs to be wider, can you do that? I'm sorry to put you on the
Sure.
spot with that. I'd love to take
No,
your take
not
your
a
take on it.
problem. So the AI industry and the AI world is fascinating. And I do think that in medicine, it really will become a commonplace to see AI technology in medicine in the very near future, by the way. So if I take a step back, I'm sure most of your listeners have heard of AI. Many of them actually may understand what AI does because, ChatGPT has made it really very accessible. So AI technology is where you actually train a system. You feed it lots and lots of data, and therefore you're training a system to actually take a mathematical equation, a coding equation, to diagnose something. So it's allowing the data to be adapted and learned, and therefore they can actually recognize certain images, for example, or certain pathways depending on the number of symptoms. So in medicine, in ophthalmology as well, it's actually being used to screen for different things like diabetic retinopathy or the idea of glaucoma, because it's very image related. So we use convolutional neural networks quite often to do that. So we actually feed the system lots and lots of pictures of what a normal optic nerve will look like, and then feed it lots of systems, lots of images that shows what a glaucomatous optic nerve. So glaucomas are a very common disease. So then the actual program can decipher which one looks normal and which one looks abnormal, and that it can be used to screen and triage patients. So I do think there's a huge role for lots of different types of diseases where AI could be oftentimes on the front line. And this technology, when it becomes more and more accessible, less expensive and easy, more portable, we can actually bring it out to communities that are rural. And that could be really the go-to triage to say, you put your chin in here, go into this automatic refractor, for example, or an auto diagnostic machine, and it can actually scan your eyes and say, do you have does this look normal or abnormal, and what it could be? And that person then can be referred to a caretaker who can do a live exam. So AI technology is very fascinating and really exponentially growing. I do think that there's a huge role. I have to say the caveat, which is we have to make sure they're accurate, right? Could you
Sure.
imagine if you get misdiagnosed? So imagine if you're screening breast cancer, and the AI says you don't have breast cancer, but in fact you do. So, that could be a huge problem, not only for the patient. There's medical legal implications, there's ethical implications, there's even financial implications. Who's going to pay for all this technology? Who's going to pay for the training of the model? Who's going to, is it insurance? Is it out of pocket? So none of that really has been flushed out. And so I think that technology is actually going faster than all of these other conversations about the medical legal implications, the ethical implications. Who owns the images? So when the patient gets all their images taken and then the doctor takes all those images and then feeds the machine, did the patient consent for that? Who owns that health privacy data? So lots and lots of fascinating questions. You could have many hours of your People Unplugged podcast. I'm there, and you probably have actually.
Yeah, no, exactly, and you're right. It's the ethical side of things. It's really a completely different world. But I was fortunate enough to do some work with one of the big car manufacturers back in a few years ago, and we were talking about self-driving cars. And I said, "Is that really going to happen?" And they said, I'll be honest with you, Paul. We've already got the technology to do that. We've got the technology. We've got the lidar systems around and everything. They can do that. We can get it driving round and round the track. We can get it stop at traffic lights. We can do all of that stuff. So why doesn't it happen? And it's interesting what you've just said there about the people forget about the ethical side of that. And he said the problem you've got is at some point someone's having to tell this self-driving car to make a decision to either drive into the wall or to avoid hitting the person who's walked out in front of the car. And he said, how do you answer that? Because we've sold this vehicle as it's safe and we're protecting the occupants, but at the same time, you have to make that split decision to say, well, actually, we better protect the occupants rather than hit that person over there. And he said, and that's the problem. So you've got that, and
That's
then
fascinating. Oh,
it
that's
is
so
fascinating.
fascinating.
Yeah, fascinating.
Yeah.
And then he said the other thing you haven't thought about, and I absolutely hadn't. He said, well, what about insurance? I said, what do you mean? He said, well, if it's self-driving, it has an accident, that's the car manufacturer's fault all of a sudden. So car
Right.
insurance is irrelevant now. You don't need it because it's not me. And he said, that's why we don't have self-driving cars. And it was just really interesting. I thought, yeah. But you're right.
That's
People
right.
don't
The
think of that.
insurance lobby. That's
Yeah, no,
right.
you're
All the
right.
insurance lobbyists.
So the technology's there, and it's similar to what you're saying. I
Yeah.
think in the UK, just going back to the medical thing, they were saying at the moment you're right. They would look through tons and tons and tons, or thousands probably, of images, and then someone would be able to look at an X-ray or look at a scan and go, that doesn't look normal, whatever that may be. And they're saying at the moment there'd be two people involved with that, so one would do it and someone else would then review it and they see what they think. So I think it wasn't, and we should say this really, just don't want to worry people, but the AI wasn't going to be the ultimate decision maker. It was going to flag things which a medical professional would then look at. That's what they're looking at here in the UK anyway for now. So,
Yeah, similarly. I think you can't, fortunately, I'm sure all the caretakers can breathe a sigh of relief that their jobs are not ending. I think we'll still need the caretakers because you're right. I think the machines are only as good as what we program. And medicine and life, nothing's black and white, right? There's so much gray area, especially in medicine, that you can't really rely on a computer to give an absolute definitive diagnosis because they haven't talked to the patient. So imagine if they say, oh, this could be breast cancer, but then you talk to the patient and they say, oh, actually, you know what? I bumped myself and this actually is just temporary. And, they don't have that additional data that a caretaker, a human, could actually listen to and say, okay, let's do that scan again in a week and let's see if it's still there. So that type of decision-making technology is still not there. It could be there. I mean, even in our lifetime, it can evolve into a system that maybe is autonomous for certain things. Hard to know. It is kind of a scary, brave new world idea that we could have machines that are making decisions that could be potentially life and death. And like you said, in the self-driving car, it's so fascinating because we do have self-driving cars. I mean, if you go to San Francisco, you see self-driving taxis all the time.
right.
I wonder how they actually decided, how did they prioritize? Is it the people in the car that you try to save or the people on the street that you try to save, right? So
how can you answer that? That's a bizarre one, isn't it? See, I've got you worried now. You're never getting in a
yeah,
self-driving taxi in San Francisco again.
exactly.
Like, well, I hadn't thought about this. How strange is that?
I'm going to a drivered, a human driving taxi next.
Just, just walk, Bonnie. Just walk. That's a better way to
Just
do it.
walk.
Unless you see a self-driving car, and then don't cross the road in front of it, just in case. There you go. Fantastic, Bonnie. Fantastic to chat. Just finish off the help me see bit. So, what regions do you want to go into next? Where haven't you been yet, or are you global?
Sure. We are global. However, we are really trying to expand in Africa. So right now in Africa, our only real training center is in Madagascar, but we're in late stage conversations with the physicians in Tanzania, in Kenya, and we just started conversations with people in Ghana as well as Nigeria. So we're really hoping to expand there. And then in Latin America, we're about to open in Guatemala as well as hopefully in Colombia and potentially in Brazil. And then we just started the conversation in Indonesia. So we are global. So,
I
it
hope you
really
track
is.
your air miles.
Exactly. That's one of the only benefits is that I get a lot of frequent flyer miles.
Fantastic. Finally, before we end, now I tend to ask everyone this on the podcast. It's one of my favourite questions. So just getting to know you a little bit. What's the ultimate weekend look like for Bonnie?
Well, my work day is 7 days a week. So the weekend probably is work, unfortunately. But besides work, so I'm so blessed to have a wonderful family. So I have three amazing, I can't call them children anymore. They're all in their 20s. And so our oldest tiger is married to Isabel. She's delightful. And then I have twin boy and girl, Sky and Sienna. And they're all gainfully employed, thankfully, and living wonderful lives. My husband, Ted, keeps me busy. And then I have two dogs that are Shiba Inus. Do you know what Shiba Inus are?
Yeah.
Yeah, they're the Doge dog, and so one is actually blind. How coincidental or how ironic that an ophthalmologist has a
You
blind
must be able to
dog.
sort that out, surely.
I wish next I'm going to turn my attention to veterinary ophthalmology, but he has glaucoma, believe it or not. So he's been blind for about a year. Fortunately, he's got a 24/7 caretaker here. But I'm really blessed to have them, and just trying to stay fit and doing some exercise. And I used to do a lot of triathlons, and that still trying to keeps me active because I like to eat a lot, so I have to move a lot.
Brilliant. Love that. And finally, funny. So, if people want to learn more, either contact you or to learn more about the work that Help Me See are doing, where can they do that?
Sure. So we are a nonprofit and our website is helpmesee.org. And we really encourage you to take a look at our website, learn what we do. Please reach out at any time. Feel free to reach out right on the website. There's a way to contact us. So reach out. So not only for awareness, but if any of your listeners are looking for a really good organization to donate any finances, any time, please reach out. We would love to work with you. And we would love to spread the word and deliver care to a lot of people.
Fantastic. Where did 40 minutes go? Bonnie, absolute pleasure. I'll see you on the other side. Sit tight.
Great. Thank you so much.
Thanks for joining us today. Feeling curious to learn more about how we help people remember stuff? Well, why not sign up for a free trial of our AI-powered bite-sized learning app, BentoBot? You can do that easily at bentobot.com. And you can catch up on interviews with all of our previous guests by subscribing to this pod via Apple Podcasts or any podcast platform. Till next time, take care.